My pleasure to introduce Dr. Russell Rockne, who's an associate professor in the Department of Computational and Quantitative Medicine with the Children Beckley Research Institute at City of Hope. He also serves as the director of the Division of Mathematical Oncology with the goal of translating mathematics, physics, and evolution-based research to clinical care. Dr. Rockne received his doctorate in mathematical biology from the University of Washington and then conducted a postdoc in mathematical oncology at Northwestern University. He's also been a research associate in neurological surgery and a research scientist in pathology and applied mathematics. In 2014, Dr. Rockne received the Future of Mathematical Biology Award from the Society of Mathematical Biology. And today he's going to speak to us about modeling interstitial fluid flow and CAR T cell therapy for brain tumors. Dr. Rockne.
Thank you. Is this on? It's all good? No, I got it. No, this. That's all right. Hi, everybody. I think we're running a little bit behind, so I'll keep it on time. Okay, I can keep some of these things short. I'm one of the few people standing between us and happy hour. That guy over there has really got the responsibility. So, no pressure, Jerry. Okay, so thanks everybody for your time. Thanks so much, Alex, for the invitation to speak. This has been a really, really great day of a lot of interesting spatial biology. I'm going to tell you about some stuff we're doing at City of Hope, which is just down the 210 from here, in case you don't know. And basically, what we're doing, I'm a mathematician, as was summarized in the introduction, is basically trying to answer this question of what is the impact of interstitial fluid flow on cancer progression in response to therapy from a spatial perspective. And I'll just explain to you how we're approaching that question. But I want to start with this slide because it highlights the real great team we get to work with, from clinicians to biologists to engineers and experimentalists, as a real integrated effort. The disease that we study is glioblastoma, which is a primary brain tumor. It has a particularly poor prognosis, for lots of reasons. It's highly invasive. The disease is very heterogeneous, but importantly, the blood-brain barrier limits penetration of therapeutics into the tissue. And many toxicities from the treatments can be life-threatening. Prognosis for glioblastoma hasn't changed in over 20 years, arguably. And so there's a real dire need for improved treatments for this particular disease. But it's characterized in many ways by angiogenesis and this tumor-induced angiogenic switch. So in your brain, the vasculature and the blood-brain barrier keep the blood intact inside the vessels. But as the cancer, the brain tumor grows, pro-angiogenic factors produce leaky and unstructured blood vessels, which create this kind of highly flow-enriched environment in the brain. And so that's why we started thinking about blood perfusion as an important biomarker in thinking about response, because it's been well known, and in fact, it's a diagnostic marker that blood perfusion is correlated with cancer grade. So lower grade tumors have lower blood flow, blood perfusion, and higher grade tumors have higher perfusion. And importantly for this symposium and this group, blood perfusion is really very heterogeneous in space within the tumor, and this is something that we can measure with MRI. And so we want to think about these features of the tumor in the context of this particular therapy, CAR T cell therapy, which you heard a little bit about in one of the talks earlier today. So I won't talk about it too much, other than to say that it's an adaptive therapy, immunotherapy, that involves extracting the T cells from the patient, genetically engineering them to express a certain receptor that targets a target protein or antigen on the tumor cells, expanded ex vivo, and then reintroduced into the patient to kind of retrain the T cells to attack the tumor. And Christine Brown is the leader at City of Hope in developing the CAR program for solid tumors, for brain tumors. And it's worth noting, in case you didn't know, that City of Hope was actually the first and to date, I believe, only reported case of complete remission of glioblastoma. It was in the New England Journal, and it was from CAR T cell therapy. So it was a patient that had multifocal glioblastoma in his brain. you received CAR T cell therapy at City of Hope, and some, but not all, of the lesions regressed, and that was a medical first, in if you will. And just yesterday, the corresponding phase 1 trial report from that effort was published in Nature Medicine. So, City of Hope really has a very strong history and leading position in developing CARs for solid tumors, and particularly for glioblastoma. And so the real barrier to CAR T cell therapy, as was mentioned earlier, is, I mean, there are several that are illustrated here, but what we want to focus on is dysregulated vasculature. So the flow of blood and other fluids in through the tumor and through the tissue is really a limiting factor in how the CARs are going to get to their target. So we want to use the data that's being collected in the clinic to start to get at this very important feature, and that is with dynamic contrast MRI, dynamic contrast enhanced MRI, DCE MRI. And what this is an imaging technique, which you see on the left here is an MRI, where the patient's in the MRI and receives the contrast agent intravenously, and MRIs are acquired over time over the course of 5 to 10 minutes. Here it's 4 minutes. And what you should observe here in this MRI picture is in that green area where this tumor, it goes from dark sequentially to bright. And that's the contrast agent leaking out into the tumor tissue. And we use that as a surrogate for the blood perfusion, the contrast agent extravasating into the tissue. And we use this very simplified mathematical model to figure out what the exchange rate constants are from the contrast agent into the tissue. And like I said, this is routinely done. So this imaging data really is very routinely acquired, but it tells us a lot about that spatial tumor microenvironment and what might be features that are more or less permissive to the CAR T cells doing their thing. But the way that blood perfusion is typically quantified, what I just showed you is with a pretty highly simplified exchange model. This isn't a big math conference, so I'm not going to go into this a lot of detail, but I just want to say real quick that we figured out a new algorithm to figure out how contrast was really moving in and through the tissue through passive and active transport by doing a regression in the function space, so to speak. So what we do is we take this moving window in through the MRI, and in each moving window we try to do an inversion or an estimation of the diffusion and the advection or flow field of the contrast agent in the tissue. And it turns out it really works. So we can show computationally the algorithm works, and then we can show experimentally that the algorithm works, okay? And what we have seen is that, in fact, the flow field or the flow of blood in and through the tumor is really, really important to understand in terms of how the CAR T cells are going to get to where they're going. And so I'll just illustrate that with this one patient example. What you're looking at the top row is the raw imaging data. The middle row is the fluid velocity field. It's difficult to see. By the way, if anybody's into fluid flows and vector fields and you have a great vector field rendering software, please come find me, because this is like a major pain, okay, to get these to look really good. I'll zoom in on them. But what you're looking at the top is the raw data. The middle row is the flow field of the fluid, and on the bottom is the perfusion map. And what you see over time, each column is a time point, is that there's this protrusion you can see with the white arrow there, where you start to see the vector field and the perfusion start to go into the contralateral side of the brain. And then you see, I don't know, it's a little obscured here. Let's see if I can. How about that? That was on the fly Zoom manipulation, by the way. Thank you. So what you see then later, 6 weeks later, is that the tumor actually starts to invade the contralateral hemisphere. And so that was something that was really was quite interesting and predictive, reassuring for us. And here's the zoom in on this. You see the tumor here on the left side, and in the red box you see these vector fields. What we notice are these few arrows just starting to point to the contralateral side of the brain across the corpus callosum, which is the white matter that connects the two hemispheres of your brain. And then you see now a stronger arrow on the second time point, and then ultimately you see this very bright lesion there on the other side, and that's makes a lot of sense because the tumor cells are migrating in and around the structure of the brain, but they're also actively and passively transported through the flow. And so what we were able to do is use this imaging data to really figure out what those flow lines were, which wasn't previously possible, and to see that that was actually predicting the subsequent tumor cell invasion. And so what we're trying to do to bring all this together, to synthesize all this together, is use mathematical models that are really tailored to that individual patient's MRI to try to figure out how best to deliver those CAR T cells. Because like I said, one of the major barriers to, as was mentioned earlier, to solid tumor CAR T cell efficacy is penetration of the CAR T cells into the tissue. But a major clinical decision point is where that catheter goes. And it's not I don't know, overly simplifying to say that in the operating room, when that catheter needs to be placed, there's a lot of flexibility in where that can go. Okay, there isn't really a very good way to guide where that catheter should be placed. And so what we can do is we can take that patient's MRI, figure out what their tumor flow field is in and around the tumor and the surrounding brain, and do some mathematical model simulations and calculations about where might be the best place to place those CAR T cells to get the best coverage in the tumor. And so for 3 different delivery sites here, you can see the simulation results top, 1, 2, and 3. The curves aren't like, let's do this. How about that? That's twice, and that's twice in one talk. That's like a thing. That's an achievement. So the CAR T cells and the tumor cell curves, can be very different. And you can see also in the simulations, the predicted distribution in around the brain and the tumor can really be very different depending on the flow field. So this is something that we can really play around with clinically in terms of delivering this therapy. And then we can even ask questions like, what happens if we just gave it in all 3 locations at once, right? Maybe we have flexibility to give more than one in one dose or in more than one location, and you can even go through and improve that coverage and that response even more. So, like I said, I promised I'd make this quick, okay? But the point here is the interstitial fluid flow and blood perfusion really are spatially varying biomarkers of cancer aggressiveness grade. That's very established, well known. But that the IFF, or interstitial fluid flow, can predict invasion of cancer cells in the brain, quantified with routine MRI, and hopefully really used to guide therapies like CAR T cell therapies that can really, and other diffusible therapies in the brain that might benefit from taking advantage of the flow field. All this and use mathematical models ultimately to do that. And so this is a QR code. This work is, I was really hoping to be published by this afternoon. You never know. You can't control some of these things. It's like in the final, I was gonna watch, I'll get the proof like as soon as I sit down. Anyway, as of right now, it's still in bioRxiv. I wanted to just note real quick that at City of Hope, if any of this is interesting to you, translating computational models, spatial biology into the clinic, City of Hope's undergoing a lot of massive growth right now, particularly in the computational space, mathematical space. I particularly am hiring. And once again, I want to say thank you for all your time. Thanks to Alex and the organizers for putting on a really nice meeting. And none of this work, this very small vignette about glioblastomas and CAR T cells, but none of it would happen without a lot of supporting people at City of Hope in my life. So thank you for your time.
The question.
All right. So in terms of the monitoring beauty experience, is it sort of the equations that you use for the perfusion, then you kind of string that together to finite elements like approach, also in time as a grid. That's how you estimate the perfusion.
Yeah. Well, I mean, if you're talking about how we estimated, I mean, I guess there are 2 elements here if I want to go back to it just for like a second. This step of estimating the flow field isn't a finite element kind of simulation. This is like a function regression. So we take all the space data and the time data, And then what this is, if you're asking, sounds like you're interested, is that this is a variation of the Cindy algorithm, the sparse identification of nonlinear dynamics algorithm. What it is, it's a regression in the function space. So what it does is it's picking out terms here in the PDE. It's that are, you know, related to the diffusivity, the cross diffusivity, or the flow or the advection fields, and it's finding out what those parameters and variables are within space, very spatially varying.
Sounds like an approach with a great wide applicability to maybe some other processes and spatial processes in tissue. Have you tried this on modeling, maybe like immune cell transport and some tissue development modalities and so on?
And trafficking, yeah, exactly. I mean, that's one of the next steps. So thanks. Yeah, that's definitely something we're thinking about. But I was excited to present this because, like I said, it should have been published like this morning, but you know, that's life. But we're really excited about next things to do with it, and that's a great idea.
Last one. This approach, so fusion equations, all use sort of Sydney application.
Yeah. Yeah. And that's a great happy hour conversation.
Any other questions? So I have a question related to CAR T cells.
Yeah, sure.
So you know, all of us were very excited. We saw that publication in the New England Journal.
Yes.
We actually have a collaboration, at least when I was at Children's Hospital, you know, with City of Hope for brain tumors. In leukemias, where CAR T cells are used often, you know, we don't anticipate immune cells getting into the CNS that easily, but yet they can control CNS leukemia. Are there potential ways in which you can track um, the migration of the cells into the CNS rather within based on blood flow and things like that? Because clinically, you know, this barrier, the blood-brain barrier has always been a huge conundrum, and people use that as excuses, I think, you know, when something doesn't work. But my thing is that we haven't really figured it out and how best to harness that. So for diseases which can affect the CNS, but have not yet or in the early stages of affecting the CNS, what are the opportunities?
Yeah, I mean, that's a really good question. I'll just say very briefly that one limitation, you know, if you will, assuming you weren't one of the reviewers, but yes, one of the limitations is that this is restricted to where contrast can be detected. So its full body application is very limited because you're only gonna get signal where the contrast agent's gonna extravasate, and so you wouldn't have a good inference of blood perfusion in any, you know, other organs. So I'm not sure how you detect it getting into CNS from marrow or circulating blood or another place. But we think a lot about CAR T cell trafficking in disseminated disease and myeloma in particular. And we use different kinds of methods for that. Not specifically blood perfusion, but it's something that we could that we have similar kind of ideas.
And it's beyond the scope of the other area which I'm really sort of interested in is, you know, in this whole evolutionary theory of cancer.
Yeah.
I don't know if you're aware of the work at Moffitt.
Oh yeah, they're my friends.
Oh, they're your friends.
Yeah.
I'm one of
So you
their
better like
biggest
it.
challengers. I mean, I keep like, you need to convince me more, but
Yeah,
we'll talk
okay.
about that
Yeah, we
as
can
well.
talk about it. Yeah.
Do you have any other questions for Russell? If not, there is a great session, guys. Thank you very
Thank you.
much.